right, it's me again talking about IOL exchanges again. This is a little bit of a less usual case. So, we brought you case one, which is the super usual suspects, and this one is maybe a little bit different. So, I think, when we think about dysphotopsias, we tend to think on the positive side, which of course is a misnomer. It's by no means a positive, thing for people's vision. But negative dysphotopsia, a little bit different. I mean, do you guys see this pretty commonly? That kind of temporal shadow that patients get?
Not uncommonly. I think if you work in refractive cataract surgery, you're going to come across this, with some level of regularity.
And I think it's one thing you just better to set the expectations ahead of time. So just
Mhm.
telling them ahead of time, hey, this is something you're gonna see. Like with multifocal, you're gonna see circles on the lights at night. And oh, hey, by the way, when we're doing cataract surgery, we're taking out this thick lens, putting this thin lens in. Normal to see the edge of the lens here early on, which gets better with time.
Yeah. Do you find that it tends to go away? Like, what kind of timeline do if patients come back with this phenomena, at week one, week two, what are you kind of counseling them on timing?
I
Well, if
typically
it's
tell them about 3 months.
Yeah.
I've done a deep dive on this recently because I had a
Yeah.
patient who came in who had cataract surgery 4 years ago and was still having it from another state. And so we were going through and looking through the data because we were just trying to figure out, what lens is best, how long does it take? But if you look at like what the percent of patients who have it at a year, I can't remember what the study was, but it was like less than 4% of patients have it after a year. And again, just showing this thing that it gets better with time.
Yeah, I believe it's 2%, but most of my patients, I tell them about a month or two. And honestly, 2% seems high to me, but that is what the data says, I believe. In my experience, I can probably give you I mean, it's hard to tell because I think patients either they just become accustomed to it, they don't complain about it at 1 year, or maybe they're not experiencing it at a year. It's hard to tell. I've
Yeah.
got one patient who is very loud about it, who has been complaining about it for about 2 years now. But that's the only one I can think off the top of my head.
And do you guys recommend like lens repositioning, like that patient if after 2 years they're like still unhappy?
I offer it for sure. I say we can surgically do something. We can either reposition that lens or we can completely exchange the lens for something different,
And then
a
they're a
different
little
edge
reluctant.
design. Um, there's things that we can do. They don't come without risk. And, she's pretty happy, this patient that I'm referring to. She doesn't have glasses for distance. She wears readers. And I tell her the same thing that, we've talked about before. Are you comfortable with giving up that freedom of spectacles, of spectacle independence in order to get rid of that dysphotopsia? And it always is, no, no, I don't want to do that. Okay, well then let's just leave it the way it is if you can tolerate it. If you can't, then we should talk. But if you can tolerate it, we'll leave it be.
Yeah. And to your point,
This
Bobby, on
last
this.
patient was the first one that I had that we finally did something about it because she was like, I get headaches from this. I'm a teacher. I'm at lunch every day during lunchtime. During lunchtime, I can't even eat because I have to close my eyes and put my head on the desk. And so, like, please, it's been 4 years. You have to do something about this white arc that causes my headaches. And then I can't even see the rest of the day. And you're like, oh gosh, we got to do something to help.
Yeah, and I find assessing these ones is a little tricky. So when you think about, positive dysphotopsia, it tends to be those kind of brighter things, whereas with this, it tends to be the shadow or kind of darker elements. One of the things that we tell patients that we'll actually assess and like physically hold your hand up to the side of their face like this, and if it blocks the light and it disappears, that phenomena disappears, is very likely to be, from negative dysphotopsia. It should improve with dilation. So in the clinic, when we're assessing these patients, we'll see them undilated and then dilated and ask them the question. We'll also use our grading scale, just because, like you guys, we have lots of doctors in the practice, and that really helps to kind of keep things even. But yeah, this particular patient's 70 years old and was referred for this phenomena in the right more than the left. So he had his left eye treated with a monofocal plus lens. I believe it was an Eyehance lens actually. In 2023, liked it so much he went back and did the right eye. His pre-op VAs were pretty bad, so I think these were probably pretty bad cataracts at the time. And his surgeon was phenomenal. He was a colleague and works at kind of a sister center and was did everything that he could for this patient. And this patient came in and we're expecting him to say the typical dark shadow. And he comes in and he just says, no, I've got this smudge. It feels like someone's taken a fingerprint and it's just in my line of sight. And so it's the way that patients describe things will often give you these little clues and maybe change what you thought your management would be and what your workup would be. And so he just kind of says he's got this smudge, there's some cloudiness, in the right, but it's 5 out of 5, so it's pretty bad. It's as bad as it can be. And then he's got a little bit of shadowing in the left, that kind of the shadow that we were expecting on the left side. Do you guys have you observed a difference in whether, if patients are going to experience dysphotopsia in the right versus the left or both? Do you feel like it's more common in one than the other?
More
I
common in
don't.
the
One thing
left.
that I have experienced though is, but I see that this is post YAG. I have had one patient in the past where they ended up having vitreous prolapse because it was a really wide YAG cap that was made, and vitreous kind of leaked around the side. And so he described it exactly the same way. It was a film or a smudge. And so my initial thought was, oh, dysphotopsia. But hey, this was like a year or two ago. That's weird. And then you look in the slit lamp and you can see vitreous kind of floating around, and oh, this is different. This is something that this is not a dysphotopsia. So that was my only thought as you're kind of going through this case.
Yeah. So it's definitely more common in the left. Like if it's gonna, it can happen in either eye, but if it's gonna happen in one, it's often the left because of the way that the nerve fibers are distributed. So I learned that a little while ago, and so fun, pub night fact, I guess. But yeah, in this particular patient, we did ask him post YAG because exactly that things can change, and so we said, okay, you had your YAG. Did that improve anything? And he said, just absolutely zero. This thing has been there since day one. So this was his second eye, and he was not happy. So we did our due diligence. We started with our anterior segment imaging here. So we've got our Anterion images there. We've got our MAC OCT, pretty clean there. We've got a, little bit of a, not quite detached PVD there. But otherwise nothing to write home about. Macula is clean, flat, dry. Lens is beautifully positioned there. Nothing untowards that I can see here. We've got our HDA analyzer here. Again, maybe a little bit of a difference in the right and the left, although sorry, that is reversed there. Endo cell count, not too bad for someone in their 70s. So not too much in the way of clues here. So we kind of move on to our dilated exam. We look at the patient. And again, this is a monofocal lens, so it's not, it's not as sensitive perhaps as some of the other, presby correcting lenses that we use. And so we're sort of wondering, we're trying to figure out what's going on here. This guy's exam is perfectly clear until we get here.
Mm.
And so everybody all along has been convinced that this poor man's lens was just the issue. And we went back and forth with him on his history, and this is what came up on his field. So he's got a superior arcuate or near total superior loss there, and you can see the pictures of his nerves, which is again why we love the compass field, because you can see that there. Pretty crowded, nerves. We looked at his lens power. It's probably pretty hyperopic beforehand. And of course, this is, an NAION. And so, I mean, the moral of the story here is essentially, yeah, he did have negative dysphotopsia in the left eye, but it really wasn't all that bothersome to him. I mean, we could reposition if he wanted. Obviously, at this point, he was not super interested. But the right eye, that smudge, that kind of weird thing that this man was describing, very, very bothered by, was of course not related to the lens. And so it's a tough conversation to have with the patient, talk about their risk factors, and we ultimately ended up referring them out for a workup. I don't think much is going to happen there, but lens exchanges don't always kind of it work out the way you think that they're going to. Those consults don't go the way that you think they're going to necessarily. I mean, if this particular gentleman had had a multifocal IOL, I mean, what would you guys be thinking if someone walked in with that field defect and they had a multifocal? Would you be considering an exchange?
I knew this is a case I presented recently where a patient came in about 6 weeks, 7 weeks after cataract surgery, and everybody thought it was going to be CME, and they had NAION. And so I think, key point with NAION is, make sure you rule out giant cell. You do blood work, ESR, CRP. Remember the top four risk factors: high blood pressure, high cholesterol, high blood sugar, and then of course a disc at risk. So controlling those first three, because 25% of the time it can go to the other eye. So I mean, first thing is like, let's get the systemic stuff under control first. Then once everything is under control first, like in the case, our patient ended up having an A1C of 13.4. So I was like, okay, let's get that under control.
Is that bad?
And, yeah, yeah. And then we can have a conversation of, okay, what do we do with this lens? Do we try to swap it out? Do we just leave it to be? Because, ultimately, if somebody's at, I can't remember, what was this patient's vision at?
I think it was like 2025
Five?
actually,
Oh, that's
oddly
a
enough,
good
with a
NAI win.
pinhole.
That's like a baby NAI win. We'll take that all day long.
Yeah.
I don't know that switching that out for anything else is going to
No,
change.
and because he had a monofocal, I
Yeah.
was curious and kind of thinking that, if this gentleman had had a multifocal, and he's now got such reduced contrast, do you consider doing anything? Obviously not immediately. And of course, to your point, he had not had seen a PCP in about 30 years, so
Mhm.
that was the first stop.
Yeah, and I think always remember, NAION number one disc edema above the age of 45 that we're going to see, and doing an MRI is always helpful because that helps rule out all the weird atypical optic neuritis or whatever the plural form of that is. And also remember on MRI when you do NAION, when you do MRI on a patient who has NAION, the MRI will come back clear. So that's what you're looking for is to make sure that you get an unremarkable MRI around the nerve.
This was a really good case, Anu. I had a patient a while back who was experiencing negative dysphotopsia. We did a full workup, and I finally looked at him, like really looked at his face, and I said, just real quick, can you do this? And he was like, oh, it's gone. Um, and so that was just kind of a teaching point for me. It's like sometimes I just need to look at my patient and see if there's any kind of dermatoclasis that could be affecting the field of vision. I've had a handful of cases where a blepharoplasty solved their negative dysphotopsia, which obviously wasn't the problem to begin with, but they didn't notice it until after cataract surgery. And so that was one where I'm chasing down lens problems. And to your point, it's not always the lens. It's a good case.
A good bluff can actually solve very advanced glaucoma sometimes for the same reason you keep the
Yeah.
lids
Sure
for
can.
visual field, right? We've all been there.
Oh yeah, some tape also does some wonders.
I think this is just a great case in just showing, when things don't make sense, like it's never a bad idea. If somebody reports decreased vision and you can't figure it out, like the two go-to tests for me, fundus autofluorescence to see if there's something I'm missing at the macula, because I've probably already done a Mac OCT, and visual fields. Like it just helps you. Like you'd be surprised how many times you're like, oh wow, okay, yep, that's an old artery occlusion, or oh, that's an old vein occlusion, or oh, that's NAION. I mean, great case.